Hi there, Mr. Hill. I have the results of your tests. Please, call me William. Right, William, your test shows that it's negative for a pulmonary embolism, which means that you have a less than 2% chance of this being a blood clot on your lung. So what you're saying, despite a negative test, I still have a 1 in 50 chance of this being a pulmonary embolism? Well, I suppose if you put it that way, yes. Don't you think that's a bit risky? Well, I suppose it is. Am I really safe to go home? Are you really safe to go home?
Risk can be defined as the probability of danger, loss or injury within the healthcare system. Risk in the NHS is managed at a macro level, with government risk registers and government policy. At a meso level, our organisation has risk registers, risk publications, and is continually developing guidelines, policies, protocols and procedures. This discussion will focus on the micro level, me the practitioner, how risk has influenced me when making clinical decisions. The emergency department is a risky place. High volume of patients, busy environments, time constraints, and the potential life-threatening pathologies that we see day to day. Risk is a complex subject, but I want to focus on what risk means to me and how I deal with risk. As the esteemed diagnostician William Osler once said, medicine is a science of uncertainty and the art of probability. This is a concept I struggled with. All my training focused on taking a clinical history, clinical examination, and along with the aid of diagnostic testing come up with a final diagnosis. I found it very frustrating when a clear diagnosis would elude me. Then I read a piece of work by Dr. Simon Carley where he suggests actually we should be called prognosticians rather than diagnosticians. However, he does stipulate that prognosticians is a made-up word. But the premise is that he suggests that we are putting a risk probability label onto a set of symptoms rather than making a fixed diagnosis. Then we apply diagnostic testing to either lower or increase this risk. Then we make a decision based on our final risk calculation. This is simple if we are dealing with obvious high-risk patients, such as a patient with chest pain with ST elevation on the ECG. We know it's not a 100% chance of being a heart attack, but the risk is so high that patients will benefit from aggressive treatments such as PCI. But what about the assessment of well-looking patients? The assessment of well-looking people who could have a condition that could be life-threatening at some point in the future, these are the patients that cause me the most distress. And I often ask myself, am I missing a life-threatening condition? I suppose the next thing to discuss is what is a misdiagnosis and how does that influence our decisions. When I first started practicing, I would have said that I never want to miss a diagnosis and that it would never be okay to miss a diagnosis. Therefore, the possibility of missing 1 in 50 patients with pulmonary embolism would have terrified me. It's important to refer back to William Osler's words. There is no 100% perfect diagnostic tests. I have to accept clinical uncertainty and that I will miss a potentially life-threatening condition, which in the very nature is medicine. Weingart states that a good clinician and a good healthcare system has to accept this. Unfortunately, we don't have the resources to investigate everyone to the maximum who attends the emergency department with symptoms suggesting pulmonary embolism. We would increase the risk of ionizing radiation and adverse effects from anticoagulation. We could do more harm than good. This is an important concept to understand, the risk-benefit ratio. Not just to the individual patient, but to the healthcare system as a whole. When considering risk, it is important to understand what a misdiagnosis might mean to the patient. For example, a missed fracture might result in delayed treatment and discomfort, but would preserve life and wouldn't be too much of a problem, whereas a missed subarachnoid hemorrhage might result in the patient's death. Therefore, risk calculation can be made based on potential outcomes. This brings us back to the scenario. Is a 1 in 50 risk acceptable? Carley and Weingart suggest a 98% rule-out rate is an acceptable miss rate. But remember, we are not ruling 100% out. What we are saying is that the risk is low, and doing further testing may be more harmful than the risk of it being the disease itself. So adopting this strategy suggests I will miss some of these critical diagnoses. Over time, I have grown to embrace this concept. I don't feel I am taking more risk, only that I am accepting risk better. Managing risk is a massive factor in good emergency care. This made me look at myself as a risk taker. Before becoming a practitioner and making clinical decisions, I would have considered myself a risk-averse kind of person. I don't speed in the car, I drink alcohol only very occasionally, and I've never smoked or taken drugs. The literature suggests that people with pathological gambling, alcohol and drug abuse is associated with increased risk-taking behaviour. Despite this, I have known to take the odd risk. In 2008, I did this. And I also did this. So I'm not completely without risk-taking traits. I'm not an anxious person. Research again has shown that anxiety disorders are associated with risk aversion. I seem to fall somewhere in the middle. My personality does dictate how I calculate probabilities of risk. Research states that medical students with an interest in emergency medicine showed to have a higher tolerance towards physical and psychological stresses, a more positive attitude towards the medical profession, and significantly higher scores in the dimension of readiness to take risks. This is interesting, as my passion has always been emergency care, even before starting my nursing career. I wonder if I've always been programmed to take calculated risk. The more reading I do on the subject of risk, the more comfortable I feel about managing risk in the emergency department. Back to the case of William Hill. A 1 in 50 chance of missing a pulmonary embolism after suitable testing, in fact, is a little misleading. This assumes that all 50 patients have the disease. Not everyone I see with symptoms suggestive of a pulmonary embolism will actually have one. Given the prevalence is about 7% of a PE in a population, only 1 in 50 of that 7% will be missed. This means out of approximately 500 to 600 patients, 1 or 2 will be missed. This miss rate is approximately 0.2%. This seems more palatable. However, we are still missing patients with pulmonary embolism of a rate of 1 in 50. After I explain this to the patient, the risk is accepted, and with good worsening advice and safety netting, this encourages the patient to return if symptoms worsen. This ensures that if I did miss a critical diagnosis, that it might not be missed next time they present. In conclusion, risk management at a micro level is complex. It has many factors. I believe to be a good probabilistician takes time. It's a skill that can be learnt through both experience and from within the literature. Risk taking is a vital skill within the emergency department, and one I will keep developing. Thank you for listening.
So William, after that explanation about risk in the emergency department, you can see it's safe to let you go home, and we have to accept some form of risk. No test is perfect, and no test gives you a 100% rule out rate. So yes, I think, William, it is safe to let you go home. Oh, that's great. Thank you for your time. Do you fancy playing some exploding kittens? Whoa, whoa, whoa. Exploding kittens? That's a bit of a risky game, William. I don't think I'm prepared to play that with you. Thank you. You have a nice day, William. Bye. See you later. Thank you. I'll just play on my own then, shall I?